what we did at SITC was to present data that we've done trying to evaluate the utility of a predictive biomarker. So the reason that that's important is that the majority of patients with metastatic melanoma are treated with immunotherapy, be it dual agent checkpoint blockade or monotherapy. However, we have no way of determining in the clinic who's going to benefit and who isn't. And so that's really the task that we've taken on, like so many others. In deciding which biomarker to look at, it's important to note that historically there have been many genomic, proteomic, multi-omic approaches that have been attempted. But the field has really been historically limited by an inability to analyze such enormous sets of data and also to have this be reproducible and scalable. We focus on glycoproteins in part because you probably know that there are many more glycoproteins than there are proteins or genes. In fact, there's about a quadrillion glycoproteins. And so by looking at glycoproteins, you're really exponentially expanding your potential biomarker repertoire. So with all of this in mind, Interven developed an LCMS, liquid chromatography mass spectrometry assay, and coupled this with an AI algorithm. So you're looking at mass amounts of data, now you can analyze them. The draw of this, from my perspective as a clinician, is that we're using blood. We don't need tumor. And the obvious draw is it's less invasive, et cetera, et cetera. And this can be done with 100 microliters of serum or plasma. The data that I presented was taken from plasma because that's what had been banked. We had a discovery cohort of 202 patients, and we identified 596 biomarkers. 521 of these were glycosylated proteins and 75 were non-glycosylated peptides. These were included for control. We then used the LCMS AI algorithm, and in so doing, we identified differentially abundant glycoproteins and made a signature. And the signature was modeled on overall survival, which was really a very important point because a question I got asked a lot over this past weekend at SITC was, how do you know you're really measuring OS? Well, it's because we censored at the time of death. We didn't censor at the time of progression. And so in doing so, we've accounted for subsequent therapy, et cetera. So we modeled on OS, but then we broke down the data or the cohort into 3 groups to get some more clinical granularity at the data. We broke patients down into 3 cohorts. The first was those with early treatment failure, meaning they died less than 6 months into their treatment. The second group were those with intermediate control, meaning they were progression-free between 6 months and 3 years. And the third group were patients with sustained control. They remained progression-free for at least 3 years. And once we broke down the cohort this way, we were able to very clearly see on the heat map with a false discovery rate of under 0.05 that 143 peptides were differentially expressed. Taking this a step further, we were then able to see that there was a signature of 14 peptides, 13 glycosylated peptides and 1 non-glycosylated peptides. And this signature allowed us to predict with high fidelity which patients were going to be in the early failure, sustained control, or intermediate control group. And we showed all of these Kaplan-Meier curves at SITC on Saturday evening. We found so we had a discovery cohort of 202 patients, and the discovery cohort was broken into a training set, a validation set, and a test set. And I will point out the test set was not utilized until the entire signature and the algorithm was totally locked in. So this gave us an extra layer, if you will, of rigor, blinding, etc. And we were able to show that using this 14 peptide signature, again, 13 of which are glycopeptides, we can very clearly demarcate in the Kaplan-Meier curves the early failure from the sustained control. In our training set, which is, the biggest part of the discovery cohort, our hazard ratio was just over 10. So we can tell who's 10 times more likely to die of melanoma. When we break this down into our validation set and our test set, the hazard ratios held up very nicely between 2.7 and 3.5. So again, we can predict 2.7 to 3.5 times who is more, that many more folds likely to die of their disease. The signature was then taken from our discovery cohort, which was 202 samples from MGH, and applied to an independent cohort of 27 patients whose samples came from Australia. So a different continent, again, another layer of rigor. And we found that the signature upheld itself very well, and we were able to tell who was almost 6 times more likely to die of their melanoma. So that's the first piece of the story. It's a glycosylation signature. The second piece of the story I will briefly tell you was our emphasis on looking at fucosylation. So fucose residues, of course, are a different type of sugar on the glycopeptide. And we found that if a patient had fucose residues, they were going to do worse in terms of overall survival. So as a clinician, this is meaningful to me because we're not just asking about PFS or we're talking about survival here. And so the next step, needless to say, now that we see this very interesting signal, now that we get a sense of the promise of glycoproteomics, now that we know how to do this on the LCMS AI algorithm, the next step is really to validate these findings.